I think that's pretty much everybody.
Recording in progress.
Okay, so tonight we will start the first of two lectures, going over the procedures section of the registry examination. Um, we'll start with the upper extremity and then move to the spine. And I know it says bony thorax, but history has taught me that we never have enough time to get to the bony thorax. We'll push that over to next Monday. Uh, there are some special slides during the presentation. This presentation is rather long, uh, as far as the number of slides go, with 155 of them, but a lot of them have questions, and you'll see as we go through, some of them have pop-ups. They leave blanks and give you time to look at it and maybe get an answer in your mind. We're going to skip a bunch of those slides just because it takes up a lot of time to ask the question, let you think about it, and then have several of you type some answers back. So we'll let you do those on your own time when you have your computers all to yourself. So with procedures, remember there's only 66 questions on the registry out of the 200 that are going to involve procedures. And that is going to be quite daunting to begin with, considering you don't just have to know the bones, you have to know the landmarks, all the different tubercles and fossas and specific names and the order in which they come in, as well as how they appear radiographically, how they should appear in various projections. So there's quite a bit of information, but again, use the ARRT specifications and be sure to go through Appendix A and Appendix B in that manual so that you can check off all the things that you need to know. Now, one thing else I want to go into before we get into this, I want to go ahead and say whatever it is that you do in clinic, be it a positioning or a special method for doing a specific view, or even the protocol, get rid of it, toss it out of your mind. It's good for when you're working, but for the registry, they want to know what is taught in the texts. So you have a text, make sure you review that information. The angles and tube angulation, body angulation, positioning lines, all of those degrees are all important numbers to know. So you're going to have to make sure you buckle down and go through those as well. Also know that muscle memory does not play a role in radiography. There's no such thing as knowing when you've angled 7 degrees with a tube because of muscle memory. I've been playing guitar for 42 years, and I can tell you for a fact it takes much, much more than doing 3 skulls a day, every day of the week, to get muscle memory for the degree angles that you have to put. Don't let anybody tell you it's muscle memory. Make sure you use the measuring tools and you know the degrees that are necessary for all those procedures. That said, the questions will cover positioning. So we're looking at the topographic landmarks, all the body positions, the path of the central ray, along with the mobilization devices and respiration instructions. Anatomy will include the physiology. It's going to have some basic pathology, not much more than you've already covered. Also, the related medical terminology that goes with that. There'll be some procedure adaptation, especially when it comes to body habitus and those with large and elevated body mass indexes. or indices, as well as trauma, pathology, age, limited mobility, so all special considerations. And then evaluation of the displayed anatomical structures in the images, including positioning and two-part receptor alignment. Oops. So general considerations, we're looking at the body planes, body habitus, topographic landmarks, positioning terminology, and skeletal motion terms, which really come more into play when we're looking, we'll see more of those when we're looking at the spine. Body plane review. Of course, sagittal divides the body into left and right aspects. Mid-sagittal divides us into equal right and left halves. Coronal is the plane that divides the body into anterior and posterior aspects. Mid-coronal divides the body into equal anterior and posterior halves. Transverse is the plane that divides the body into superior and inferior aspects. Body habitus. So our sthenic is what we uh, refer our average build patient to, their height and weight proportionate. Hyposthenic, remember hypo is the prefix meaning below or under. Uh, these patients will be tall, thin, seem to be less robust than the sthenic patient. What do we call the stocky, robust, and chubby patients that are above or over the average build? Well, those are the hypersthenic patients. And then the small, thin, frail patients, approximately 10%. We're looking at those patients being referred to as asthenic. Okay. Um, Along with the different descriptions of body habiti, you need to be familiar with the way the organs lay out in the abdomen and the chest in relation to that body type. And I know we've seen this, we may not have seen it. There'll be another set of slides that'll go a little bit more into the layout. We'll look at and see these body habitus again when we get into contrast studies and the special procedures in the Procedures 2 lecture. So our topographic landmarks, for the most part, the column on the left is the internal structure, and the column on the right is the palpable landmark itself. So C1 corresponds to the mastoid process. C3, the mandibular gonion. Here. C5 corresponds to the thyroid cartilage. C7 and T1, that's going to correspond with the vertebra promens. T2, T3, the jugular notch. T4, T5, approximate the level of the sternal angle. T7 and T8 correspond to go, go. It won't roll forward. The inferior angle of the scapula. Okay, going to T10 corresponds to the xiphoid process. Kidneys in that area of T12, L3. Notice you can't palpate the kidneys. L3 corresponds to the inferior costal margin, so the bottom of the rib cage. L4, L5 at the iliac crest. For most patients, greater trochanter corresponds to the level of the symphysis pubis. More terminology. Remember that projection describes the path of the central ray. Position refers to the patient's physical orientation in space. Radiographic view, it's antiquated in its usage, but it does refer to the body part as seen by the image receptor from the image receptor's perspective. The decubitus, patient's recumbent and performed with a horizontal beam. Axials are projections that use an angled CR. Projections that skim a body part are known as tangentials. Supine is a position of the patient when they're recumbent with their face up. Prone is that same patient recumbent but the face down. When a patient's recumbent with their head lower than feet, that is term for that is Trendelenburg. And when the feet are lower than the head, that's Fowler's. The position that we utilize for most barium enema tip insertion, where the patient is in a recumbent oblique position on their left side with the right knee flexed, is known as the Sims position. The oblique is going to be when we place the patient in an angled position. Skeletal motion terms. Pronation, the hand is rotated palm up. I'm sorry, palm down, pronation. Supination, the hand is rotated palm up. Abduction, we move the limb away from the body. It's being abducted from the central midline. Adduction is when we move it towards the body. Flexion is when we decrease the angle of a joint, and extension is when we increase the angle of a joint. So flexion on an arm, that's 180 degrees. We decrease it. That's flexing. At bent at 90, extending would be going up to 180 degrees. Distal, proximal, of course, is closest to the origin of a structure. Distal is the portion away from the origin, anterior towards the front, posterior towards the back or behind. Classifications of our bones. Short bones are the tarsals and carpal bones. Long bones include humerus, femur, tibia, fibula, radius ulna. Flat bones include the sternum, ribs, and the skull cap. So flat bones are not necessarily flat all the way through. It's just that their one dimension is smaller than another dimension by a great deal. Irregular bones include the vertebra, facial bones, bones of the pelvis, and those that make up the base of the skull. Sesamoid bones, typically found in tendons at joints, the largest of which in the human body is the patella. Terms associated with ossification. The diaphysis is the shaft of the long bone. This is the center of our primary ossification. The epiphysis is the secondary ossification site. That's the ends. And the epiphyseal plate is the cartilage that joins the diaphysis and the epiphysis. And as the individual matures, that cartilage calcifies, closing the growth plates. Fractures. Your simple fracture is closed, meaning it does not break the skin. Compound fractures are when we have fracture pieces that actually go through the skin. Incomplete fractures are fractures that do not go all the way through the entire bone. The green stick is a type of incomplete fracture, as is the torus, which is a buccal fracture. Now you don't actually see a fracture line where we would have continuity along a path of the bone and it just kind of buckles or knurls. Green stick, we have a fracture on one side of the bone. Typically in pediatrics, where we'll see green stick fractures because their bones are still don't have quite the calcification content as adults, so they're a little bit more flexible. Spiral fracture, we have a long bone that breaks because of a torsion. These are complete as well. Quick note, if you have a spiral fracture of an ankle in the tibia distally, more than likely, greater than 90% of the time, there will be another fracture in the fibula, proximally. Spiral fracture distal tibia will almost always lead to a proximal fracture of the fibula. Comminuted is when the bone is splintered into two or more pieces. Butterfly fractures more than likely will occur in a long bone, and they yield two wedge-shaped fragments from a central point. So it kind of, they're triangular in nature. It's kind of hard to do with my hands. Odd. One. I have an image of one somewhere. But they're triangular where 2 points come down and meet on either side of the bone. And it looks like a very, very squared off and angular butterfly wing. Okay.
Recording stopped. Recording in progress.
Woo. Sorry about that. My internet just cut out. Are we back? You got the slides back up? Okay, good deal. I found another one while my computer was coming off the internet, but here's one of the did that get my face out of there? There we go. That's another butterfly fracture of the ulna. Good images. If you want, to study or have images to go along with the types of fractures, I suggest Google or going to Radiopedia to find those. Impacted when we have one fragment driven into another. Avulsion fractures are involved when a tendon or a ligament, it's actually a ligament, pulls a portion of the bone apart. Pathologic fractures are fractures that result from a pre-existing condition. So if the patient has something that causes the bone to be weak, normal everyday things that would normally not cause a fracture or an injury could result in a fracture. Lytic lesion is one of the most popular things um, that we'll see. Osteomyelitis and, of course, osteoporosis uh, can lead to fractures from normally benign activities, and those would be considered pathologic as well. Stellate fractures radiate from central point like a star. Um, and then, of course, we have our stress or fatigue fractures that result from repeated stress from stressful activities. The fracture of the fifth metacarpal is known as. Anybody want to type that in there? Better question. Yes, it is the boxers who typically gets these. Who do we typically see receiving a boxer's fracture? I'll give you a hint. It's not a boxer. Typically people who punch walls. Most of those people, they punch anything. Most of them are going to be, teenage young males. Uh, Distal radius with posterior displacement of the fragment. Of course, is Achilles. The opposite of that is anterior displacement would be the Smiths. A Pott's fracture is a complete fracture of the distal fibula. Most often will include fracture of the distal tibia and the medial malleolus as well. Moving into the upper extremity. The following slides, especially for this part, they have really good diagrams. Consider printing the slides, whiting out the writing, practice your labeling. I'm not going to go through all of these because it's just reading the slides. I'll note some things that are definitely worth noting for you, but there's no reason for me to run down through all of these names, is there? Now, when it does come to the anatomy, especially the diagrams, make sure you know all of the labeling here. So along with the tubercle, tuberosity is another acceptable term. Bicipital groove and intertubular groove, okay, same thing. The capitellum and the capitulum. The epicondyle that is lateral. So this is the lateral epicondyle of the humerus. The cap sits over or on top of the head, the radius. That's how I will remember those. Sorry. The shaft or body of the long bones, also known as the diaphysis, which we saw earlier. The trochlear sulcus, which is that groove in the ulna that the trochlea sits in, so that we get that elbow joint. There's a radial fossa as well as a coronoid fossa. Normally, we only hear and talk about the olecranon fossa on the posterior aspect of the humerus, but there are fossas on the anterior side to make room for one, the coronoid, and two, the head of the radius. Evaluating images. Make sure you're able to know and identify different parts of anatomy. Okay, now for an AP humerus, or what we would term an external rotation, the greater tubercle is going to be in profile. If we put an imaginary line through the epicondyles here, that would be parallel to the IR, perfectly perpendicular to the central ray. We want to make sure that we have both joints demonstrated on long bones and adequate penetration through the whole part. For the internal rotation or lateral humerus, again, we want the whole long bone, both joints demonstrated. And in this one, we have the lesser tubercle in profile. Epicondyle should be superimposed. So in addition to the diagrams, we've included radiographs as well so that you can work on your labeling. So radiographically, you really can't see the radial fossa or the coronoid fossa because even in this view here, that's the olecranon that we're seeing. That's not actually the coronoid fossa that we're seeing. That's the olecranon fossa that we're seeing in our radiograph. So for elbow rotation and movement review, if you have to do a 3-view elbow or even a 4-view elbow, remember that with the AP, we've got no rotation, and so that line that goes through the epicondyles should be sitting parallel to the IR. That will result in a slight superimposition of the radius and the ulna as they come together here. With a lateral rotation, an external rotation at about 45 degrees here, you'll get separation. This will allow for good visualization and unobstructed view of the radial head. Okay, also get that radial tubercle in profile. With an internal rotation of approximately 45 degrees, you'll see the coronoid process of the ulna in profile. And we'll have complete superposition of the ulna over the radial head. For our lateral elbow, we want the long bones to form a 90-degree angle here. And then again, make sure that we're able to name, label, critique the image. Our diagram. The radius and the ulna, remember in the anatomic position, the radius is on the thumb side, so it will be lateral. The ulna is medial. In addition to our articulations with the humerus, the radius has a notch for itself on the ulna. Okay, this is the radial notch, and it is on the ulna, and it is for the head of the radius. So this is at the proximal end of the forearm. At the distal end of the forearm, we have an opposite. So there is an ulnar notch on the radius for the ulna to articulate with. Both long bones have styloid processes distally. The most prominent, pointed of them is going to be the one on the ulna. Evaluating the forearm radiographically. Now, I do want you to note that over here we have on the AP, this is an adult. And over here on the lateral, we're looking at a juvenile. Okay, there's still growth plates have not solidified. So those aren't fracture lines. Those are all epiphyses. Moving into the hand and wrist. So digits 2 through 5 have 3 phalanxes. The thumb, or first digit, only has 2. So it only has 1 interphalangeal joint, whereas all the others have 2 interphalangeal joints, being proximal and distal. All 5 have a metacarpophalangeal joint, with the head of the metacarpal being distal and the base articulating with the carpal bones. 2 rows of carpal bones, with 3 of them comprising the wrist joint. For the carpals, the proximal row named lateral to medial, and the distal row named lateral to medial. Okay, so if you run across any questions and they want to know, name the carpals in order on a PA hand, okay, you always start from the lateral aspect of the hand itself. Okay. So that means you're always going to start labeling from the thumb side. When you start naming carpal bones, you start naming them from the thumb side. Doesn't matter if you're looking at the hand PA and it's a left hand and you're not, or even if it's this hand, you're not going to start from over here and label that way. Okay. You're going to start from the thumb side and label across. All right. So starting on that lateral aspect, you'll have scaphoid, lunate, triquetrum, and pisiform proximally. Distally, you'll have the trapezium underneath the thumb. Next to it, the trapezoid, the capitate, and the hamate. So the T's, since there's so many of them, you've got to kind of compartmentalize. Proximally, we have the quitritrum. Distally, we have 2 trapeze. Okay, we've got the trapezium and the trapezoid in distal row. Another thing to add on to that, both of those trapeze, last letter of the alphabet, Z, distal end of the wrist. Okay, distal row. Now, another thing that helps with that are mnemonics, and I'm sure you've come across a couple of these in your studies. Send letter to Peter to tell him to come home. Lists from lateral proximal, starting lateral distal. Okay. Steve left the party to take Carol home. It's another one. A third one, to me, seems easier to remember. Scared lovers try positions that they cannot handle. So, with the try that cues you in, triquetrum, and that they, 4 letters, trapezoid, zeum, and zoid. They're 4 letters. They're the distal row at the end of the alphabet starting with Z, but the trapezium resides under the thumb or above the thumb, depending on how you're holding your hand. Labeling and things to note on the PA hand. We should have no superimposition at the head of any of the metacarpals, but as we get down closer to the carpal bones, we'll see a superimposition of the base of 4 and 5, the joint space between 3 and 4, as well as 2 and 3 and 1 and 2. Now there's mild superimposition of 2 and 3. Yep, if you're going with the alphabet, that does make sense. I like the eom under the thumb because it rhymes. But if you're not a fan of rap music, I guess that won't, you know, always trying to figure out something. Another thing, this joint space here, this joint space right here, that's the radiocarpal joint space. If anybody asks. I know it's not labeled. Thought I'd put it in there. For the oblique, now we start to see superimposition, but the phalanges are not superimposed except by soft tissue and right here by the heads of 3 and 4. Now we start to see closing of those joints proximally with 2 and 3 opening up as well as 1 and 2. For the fan lateral, which we use when the patient has a history of trauma, okay, we're looking for fractures with the fan lateral position. If we do an extension lateral, we're looking for foreign objects. So here, everything, we're not going to be able to get all of the metacarpals completely superimposed. And we're going to have a little bit of offset here with the radius and the ulna as well. In a hand, in a wrist, we should see a smooth line right back here. We'll look at the wrist in a little bit though. Again, good for labeling. This is the first of some of these questions that I was talking about. What method is used to x-ray the carpal canal? How is it performed? Well, it's performed by utilizing a central ray of 25 to 30 degrees towards the hand. Okay. Rotate the hand and wrist from vertical to 10 degrees towards the radius. CR is about an inch distal to the base of the third metacarpal. So about right there. So remember the base is here, and to go distal of the base, you have to go up. Okay. That's distal. Going this way is going proximal. So watching the way things are worded in the questions is going to be very, very crucial to making sure you understand and finding the right answer. Anyway, this is the Gaynor-Hart method. All the projections, because I'm sure if you've looked at Merrill's, even in Bontrager, there's lots of extra views, lots of views for all body parts and areas. The registry is specific about the views it's going to ask questions about. So even if you do study the Merrill's, there's a bunch of views it's not going to ask you anything about. Use the checklist. Use the ART specs. The Stetcher, used to demonstrate which bone. This is 2 of the 4 methods of doing the Stetchers. But we're looking at the scaphoid. How and why is an AP partial flexion elbow performed? Why do we have to do 2 views here? because the patient can't extend their elbow. Well, the elbow's already bent. We want them to straighten it. So anyway, I'm going to zip through some more of these. It could be hardware. Typically, hardware is not going to make it unable to be straightened. I mean, the whole purpose of putting in hardware is to reconstruct the joint and make the bones good so the joint works. If there's a problem with it bending, it's typically going to be from trauma prior to surgery. So again, I'm going to go through these pretty quick because, oh yeah, we got more stuff to do. Shoulder, our internal rotation. It's going to get our lesser tuberosity in profile. Okay, this is our internal rotation. In this position, just like with the humerus, those epicondyles, if we have a line going through them, that should be parallel to the CR, perpendicular to the IR. Different parts of the anatomy. The costal surface. Okay, so remember, costa is medical terminology for rib. Okay, so this is the rib side, the costal surface. This is the anterior. The dip that's built in here is known as the subscapular fossa. Again, you got to know all the terms. For the body is also known as the blade, the wing, and like the pelvis, the ala. Scapula does have a neck, sits behind the glenoid cavity or fossa. The lateral angle makes up the head, sits distal to the neck, and the subscapular notch sits about the level of the coracoid. Coracoid. Never chew nails. For coronoid, coronoid, never chew nails. And then the superior angle and the inferior angles of the scapula. For evaluating the scapular Y, we want to make sure that the blade is visualized in profile. Remember, it's the acromion and the upper spine portion of the scapula. It's this line of the scapula that leads to the superior angle that makes that other portion of the Y in this view here. That's that portion right there. That's the superior angle, inferior angle. You can see on this one here, the humeral head is not sitting over the glenoid cavity. So we have an anterior dislocation. When you do these from internal, external going to the Y, typically you want to use about 85 kV on your scapular Ys. That'll allow you to drop the dose down. Collimate tight. I'm a big proponent of manual techniques. It takes practice and diligence to become a good techniquer. Lower extremities. Anybody have any questions at this point? Okay. I'm not going too fast, am I? You guys okay with the presentation so far? I feel better by not reading all of that stuff to you. I think that's something that y'all can do. Okay. All right. So moving into the femur, lower extremities. Couple angles that we don't talk about. A couple things that we don't really discuss either. The femur articulates with the pelvis with the hip joint. Okay, so the femoral head sits in the acetabulum, and we have our femoral neck, which is also the surgical neck. Remember, on the humerus, we have an anatomical neck up by the head, but the surgical neck is below the greater tubercle on the humerus. Here, the surgical neck and the anatomic neck are the same thing. Now, as we go distal and come to the intertrochanteric groove and the greater trochanter, there is about a 15 to 20 degree angle. So the femur actually goes backwards, goes posteriorly about 15 to 20 degrees, and then starts on its downward trail. Now it leans in and traverses medially anywhere from 5 to 15 degrees. Okay, this puts our femoral neck and shaft at roughly a 125-degree angle. Okay, plus or minus 15 degrees. Again, everybody's not the same. Because of this, we have this 5 to 7 degree angle on the condyles, where the medial condyle sits distally, actually below the lateral condyle. This is why on our lateral knees, we angle 5 to 7 degrees cephalic on a medial to lateral knee projection. Because of this 5 to 15 degree angle, anatomically, we should get parallel to the floor. This is normal gait. Okay, when we're doing standing knees, and I've seen this on many a discussion board, the big question is, if we're doing weight-bearing knees and we're doing a lateral weight-bearing knee, do you angle the CR 5 degrees or do you keep it horizontal? What are your thoughts? What have you seen and experienced? Good. Got a couple horizontals? No angle. That's good. I like seeing that. Now, on the forum that I was looking at, there were a lot of people who were like, always angle on the lateral. I'm angling, angle, which, there is a method of doing the weight bearing knee without having to do the angle, but it has to do with setup. And it really does have to do with setup. In our normal position, that femur is going to angle medially as it goes towards the knee. But when we're standing up trying to take pictures, the normal inclination is to have that femur, even for the patient, is to put that femur vertical. And so they put that 5 to 7 degree angle on their condyles just merely by positioning. And so what you typically end up doing is adjusting, having them lean. I have the patient lean in their hip to just cause a leg to go this way towards the IR, and that puts that 5 to 7 degree angle, and I shoot horizontal. Epicondyles are always level when I do that. Let's see, intercondylar sulcus in the femur, the trochlear groove, the intercondylar fossa notch posterior on the femur. Remember, the popliteal surface is on the posterior aspect of the femur, and the lesser trochanter is as well. It's on that posterior aspect of the femur. Moving to our lower leg, just like our humerus, just like our radius and ulna, the tibia and fibula have notches for articulation as well. So proximally, we have a tibiofibular joint here. And distally, we have a tibiofibular joint here. So we've got a fibular notch for the tibia. Okay, so in the big bone, or in the little bone, we have a notch for the big bone distally in both areas, the forearm and the lower leg, and vice versa. We've got a notch in the big bone for the little bone in the lower leg and in the forearm. Intercondyloid eminences, the tibial spine, the medial and lateral intercondyloid tubercles, all of these names we need to have down pat. Moving into our foot, digit configuration, same as the hand, with the exception of the first digit is now medial on the foot. Okay. First digit is medial on the foot. The first digit is lateral on the hand. Metatarsals are going to be labeled 1, 2, 3, 4, 5 from medial to lateral. Then we have our tarsal bones. Radiographs of the AP foot, a medial oblique, and this is a weight-bearing lateral. Again, you need to be able to identify all of the different bones in the tarsals and distal portions all the way into the digits. Note that we have superimposition at the base of all the metatarsals with the exception of 1 and 2. In the oblique, we separate 2 and 3, 3 and 4, 4 and 5. And we get a much better view of the joint spaces between each of the tarsals in the obliques. They're kind of obliterated here. Then we have our yes, there is. The talus and the tibia go together to form part of the ankle joint. And it's at the end of the talus that you have the navicular. Okay, so the talus and the talus and the calcaneus, or the os calcis, they sit beneath the lower leg, and the navicular sits out in front of the talus. So even when you're looking at them this way, that round dome, there's a talar dome here. When we're looking at it from above, it's domed as well, and the navicular just kind of sits like a hat on top of it there. Same thing in our oblique. It's short and kind of, it's shaped like the scaphoid in the wrist, flipped upside down though. Okay, so the scaphoid comes this way. Well, the navicular is going this way. And I don't even know when they changed the name, but when I went through school in the early 90s, this was the navicular scaphoid. And I mean, we had a navicular in our hand and in our foot. So that made it easier for me to remember. And then they changed it and they dropped the navicular off of this and just left it as scaphoid and let the foot have the navicular. So when we get a lateral, that talus should be medial to lateral, should be superimposed. So we get a nice, even, hard line across that talar dome. Oh, one other thing I want to make sure I note. On the cuneiforms, there are 3 of those. They can be first, second, and third, or they can be medial, intermediate, and lateral. Okay. The very, very outside, distal, outside, um, tarsal bone is the cuboid. Okay. That's the big one that we're seeing here on the lateral. It's also this one here. Now, the largest tarsal bone, of course, is the calcaneus. That's going to be a proximal. The talus will be second, also proximal. The cuboid would be the third largest. Moving into our pelvis, we have 2 hip bones, the ossa coxae, and then the innominate bones. Okay. Got the sacrum and the coccyx to make up the pelvis. Now, breaking up the hip bones themselves, on each side we have an ilium. That's ILIUM, as opposed to the part of the small intestine, which is ILEUM. Then the superior portion of the brim of the pelvis, made up of the pubis bone. At the ischial tuberosity, we have the junction of the pubis and the ischium itself, which travels posteriorly. And all 3 of these bones, the ilium, the pubis bone, and the ischium, make up the acetabulum and the proximal portion of the hip joint. So, reviewing anatomy here. Good slides. Good slide. Again, this is going to be on a juvenile, but it doesn't change. Okay, C here would be the ankle mortise. This is the talar dome here. The epiphyseal plate of the tibia. Medial malleolus, lateral malleolus, fibula, talus itself. Okay, so there's quite a few of these that are available to you. Special views of the knee. Looking at the intercondylar fossa, the first of which being the Camp Coventry, otherwise known as a tunnel view. Now, the patient is going to be completely prone, and the knee will be flexed 40 to 50 degrees with the foot being supported. CR, even though the CR has a 40-degree angle on it here, caudally, this CR is perpendicular to the lower leg. So when you're doing the Camp Coventry, depending on how much the patient's going to be able to bend their knee, if they can get it to 40, 50 degrees, 40 is going to be better. Okay. That's what we'd like to see is 40, because it doesn't require as much of a bend. But then that makes it easy to put this at 40 as well. So that'll give you that perpendicular. Center to the popliteal crease. Okay, so the CR will enter the popliteal crease, and it should exit the intercondylar fossa. So nice view. We've minimized OID with this one. The opposite of this is the Beauclair. This is also known as an AP axial. This is an intercondylar fossa as well. We've increased the OID here, so there's going to be a significant amount of magnification. But again, the knee is flexed 40 to 45 degrees. CR is perpendicular to that tibial line. Okay, we're going to center 3/4 of an inch distal to the patella in this bent position. The Holmblad is a modification of the first one, Camp Coventry. I remember this one because the patient is on all fours, and you remember if the patient's on all fours, they're at home being bad. The Holmblad. Patient is kneeling. The femur is at 70 degrees to the tabletop. Okay. This should be at not parallel to the tabletop. This will be at 70 degrees. And remember, we're not going off of the hamstring because this is soft tissue. The femur is residing mostly anterior in the thigh here. Okay, so we're going off of that. Have the patient lean forward 20 to 30 degrees from 90 degrees, and then have the CR enter at the popliteal crease. It will be perpendicular to the IR. The modification of this is the Houston. This is for the Sunrise. Okay, so the Holmblad is for the patella. Actually, no, the Holmblad is for the intercondylar fossa. The Houston is for the patella. This is an axial or a tangential view here. Knee is flexed 40 to 45 degrees, and the CR is 15 to 20 degrees to the lower leg. Okay. You can use a sheet or a pillowcase or tape, however, patient can hold their ankle and then hold on to the other ends there, and that'll hold their leg there. Or if their leg is long enough, you could pad it so that it ends up resting on the collimator housing. So we get good separation of the femoral popliteal. Femoral patellar joint space here, popliteal, I'm sorry. The next one is the Setagast. Here we've got the knee flexed to a full 90. Still 15 to 20 degree relationship between the CR and the lower leg. Okay. Then we have the Merchant. This requires a special holder so that the IR can rest on it against the lower leg, and we shoot tangential. Knees are going to be flexed 40 to 45 degrees and from horizontal. Okay, so we'll set it up to shoot horizontally and then drop it 30 degrees that way, 30 degrees down. The opposite of this is simply named the infrasuperior projection. We're going from the bottom to the top. Notice that the patient is recumbent. This is to keep their eyes and thyroid out of the path of the CR. I know there's quite a few techs that will do these in facilities, and they'll have the patient sitting up holding that IR with their hands, and of course it's exposure to thyroid and lenses. Flex 40 to 45 for the patella, and for the intercondylar fossa, 40 to 45 degree flexion is paramount. It's popular for this. CR will be angled 10 to 15 degrees infrasuperiorly. Now there may be other projections for getting these intercondylar fossa and the patella, but those are the only ones that you have to worry about. Which SI joint is being demonstrated in an RPO? of the SI joints? Well, it's going to be the left. It's the side up. This is the one oblique projection where we will probably mark the side up as opposed to the side down. And the reason for that is most facilities, when you do SI joints and do the obliques, you're only going to get one SI joint. And so you want to make sure that you're labeling the correct side. And in this case, for an RPO, it's the left side that's up. 25 to 30 degree oblique. CR will come in perpendicular 1 inch medial of the as is, the upside as is. Bone measurement. Okay, this is one of those special ones here. Doesn't matter what your facility does. Okay. For long bone measurement, we want AP hip, AP knee, and an AP ankle. For a metabolic bone survey, don't care what you do at your facility, this is what the ARRT is looking for. So AP and laterals of the femur, tib fib, humerus, and forearms, AP and lateral of the skull, CT and L spines, bilateral ribs, PA of both hands, APs of both feet, and an AP of the pelvis. So here, this starts the quiz slides, and I'm going to go ahead and skip through these because there's a lot of them. And like I said, it does take a lot of time to get through them. These are good for you to go through, though, because they ask good questions. And I'm sure you could appreciate as many of these slides as there are, there's only going to be 6 questions or 66 questions on the registry. My goodness, everything you got to know. Why do we use 10 degrees for AP projections of the feet? What is the purpose of that? Okay, 2 good answers. Okay, good, good. Yes. 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 Very good. Okay, so because of the natural position of the foot when it's sitting down like that, the reason that we put that 10-degree angle on there is to reduce the amount of shape distortion of the metatarsals. Because when we're doing a foot, that's what we're looking at, the tarsals and the metatarsals. We don't get a great view of the tarsal bones. You saw that. We see the tarsal bones really good on the oblique, but on the AP, we really don't. So we're really concentrating on the metatarsals there. And that 10-degree angle prevents any more distortion that we would normally have. So now my next question is, if the patient can't set their foot flat, how do we minimize that elongation and foreshortening and shape distortion when we do that AP foot? What's a good method of figuring out how to angle our tube when the patient can't set their foot flat and we can't start from 0 and angle 10 degrees? Okay, now what are you going to use? What's your guide for your angling of the tube? And yes, you could put something under the cassette, but you still have to put that, you still have to have an angle. Towards the toes, towards the toes. So if the foot is sitting up like this, the toes are here, You're going to angle towards the toes. So like this for portable. Sorry. If the patient's foot is angled 10 degrees, you won't need an angle. That is true. But if you're gonna have a compass, a protractor, so you can measure that measurement of their foot, the easiest way and the best way to do this is to use your collimator housing on your tube. That bottom surface, okay, that flat portion of the, let me see if I can get it where you can see it. That bottom portion of the collimator housing, it's always flat, right? It sits at 90 degrees to your CR. So what you do is you take that, and however the foot is sitting, you match it so that they're parallel. And that will give you the angle that you need, because what you want is the CR coming in perpendicular to the long axis of the metatarsals. So if that's one of those things, as far as adaptive radiography, we're not always going to be able to sit at 0 and then count to 10. We're going to have to put it at a certain spot and then maybe go to 10. You'll see that next week when we talk about the skull. That's going to come in handy. That was a good slide to stop on, though. So we'll go through these. Quite a bit of them, like I said. Oh, yeah. Okay. So that's all of those for the upper and lower extremities, as well as the pelvis. Now we go to the spine. The neural arch is composed of 2 pedicles and 2 lamina. Okay, and remember, the neural arch is the opening where the spinal cord is going to go through the spinal column. Okay, the pedicles originate from the vertebral bodies, and in most cases, this isn't always true, but in most cases, the lamina are going to originate from the transverse processes. Bottom line, the pedicles are anterior to the lamina. Okay. So the neural arch encloses the what? Well, it encloses the vertebral foramen. Supports the following processes. Got 2 superior articular processes, 1 and 2. It has 2 inferior articular processes, 1 and 2. It's got 2 transverse processes and 1 spinous process. That all comprises the neural arch. Lamina, again, they're posterior portion, and the pedicles originate from the vertebral bodies. Vertebral column is composed of 33 bones. The intervertebral discs in between each vertebra has 2 portions. The nucleus pulposus is the semigelatinous interior portion, and then the annulus fibrosus is the tougher outer portion. The vertebral column, cervical region has normally 7 vertebrae, concave or lordotic curve. Thoracic region has 12 vertebrae with a convex or kyphotic curve. Lumbar region matches the cervical region in its curvature, but it only has 5 vertebrae in most cases. Sometimes we'll see 6. The sacral region has how many vertebrae? Of course, they're all fused, but there are 5 with a convex curve. And the coccyx, as an adult, has 4 fused vertebrae, also with a convex curvature. starting at the lumbar and naming the different portions, noting angles as well. Love these for labeling. Okay, visualization of the zygapophyseal joints typically happens at about 45 degrees. Okay, that's where we'll see those articulations with the inferior articular surface and the superior articular surface of the vertebra below it. So we have our vertebral body, spinal canal, or the intervertebral foramen. Our pedicles, transverse process. This is the inferior, this is the superior, because we're looking at it from the top. So this is the superior interarticular surface. And F is the lamina, with G being the spinous process. The thoracic vertebra, little bit different. So our pedicles are still here. Now the zygapophyseal joints, zygapophyseal joints in the T-spine are at a 70-degree angle. Okay. Note, for the lumbar, it was 45 degrees back this way. For the thoracic, it's 70 degrees up this way. So that means that when we visualize these zygapophyseal joints on obliques, upsides and downsides are going to come into play, but it's based on how they're positioned. So our superior articular surface is here. Here's our transverse process and our spinous process. There are some other articular surfaces on the thoracic spine that we'll look at here shortly. Your typical cervical vertebra, this is 3 through 6. Okay. 1, 2, 7 has a variance as well. But 1 and 2 are really different from 3, 4, 5, and 6. The transverse processes for the cervical vertebra come off of the vertebral body and precede the pedicles. Lamina is still posterior, and we have bifid tips for the spinous processes. The superior articular processes are more flat than vertical, as we see in the T-spine and the L-spine. Same thing for the inferior articular processes. There are 3 foramina in the cervical bodies. We've got these here and the large one for the spinal canal. You want to be able to define kyphosis, lordosis, and scoliosis. Know that spina bifida is a congenital condition where we do not have posterior aspects of the vertebra to develop or unite. This means the lamina, typically. Spinous processes may be absent as well, but it's typically the lamina where we see spina bifida. Whiplash is a nonspecific term referring to an injury from a sudden extension of the neck, which causes a reversal of the lordotic curvature. Okay, so when instead of the spine, chin would be over here. Instead of the spine being lordotic in its curve, the muscles and spasms cause that curvature to disappear. And in some instances, it may reverse it, depending on how bad the injury is. HNP is a herniated nucleus pulposus, otherwise known as a ruptured disc. Spondylolisthesis anterior movement or displacement of one vertebra in relation to another, typically seen on laterals where we would follow that normal curvature. We might have a vertebral body that sticks out further than another. Osteoporosis, of course, is loss of bone mass. List the articulations associated with the vertebral column. These are all 9 of them. So the occipito-atlantal is the skull and C1. Atlantoaxial is C1 and C2. Costovertebral is the head of the rib with the thoracic vertebra. Costotransverse is the tubercle of the rib with the transverse process of the T-spine. Of course, lumbosacral with lumbar and sacrum, L5, S1. Sacroiliac, with the sacrum and the wing of the ilium. Sacrococcygeal, sacrum and coccyx. Intervertebral, where the bodies of the vertebra articulate, and then apophyseal joints, where we have one vertebra articulating with the next subsequent vertebra. Identify at least 2 aspects of the cervical vertebral column that are unique. First thing is the transverse foramen and the bifid spinous processes. Now, this question is, of course, referring to C3 through C6, because if we talk C1 and C2, we could list another multitude of differences that make them unique. But it doesn't make them unique from being included in the cervical division of spinous. How C1 different from other cervical vertebra? It's referred to as the atlas because it does hold the head. Doesn't have a body. It's got an anterior arch in its place. Instead of lamina, it's got a posterior arch. There's a posterior tubercle instead of a spinous process. And the superior articular surfaces are very, very large because it articulates with the condyles of the occipital bone of the skull. How is C2 structurally different? It's also known as the axis, and it does have the dens or the odontoid process. That's its biggest difference, having that extension above its body and not having a typically disc-shaped body. What type of articulation is between C1 and the occipital bone? That atlanto-occipital articulation is a synovial joint. It's considered diarthrotic, and it has ellipsoid or condyloid movement. All of these terms you need to be familiar with. C1, C2 has 2 types of movement. The articulation is also a synovial diarthrotic joint, and it's got pivot or trochoid movement involving the odontoid in C1. So the odontoid and the anterior arch of C1 have pivot or trochoid movement of that arch. And then we have glide or plane movement involving the apophyseal joints between the inferior surface of C1 and the superior surface of C2. Structural components of the thoracic spine are unique. Its big claim to fame of uniqueness is its articulation points for the ribs. It is important to note that the ribs do articulate with the inferior surface of one vertebral body and the next superior surface of the next vertebral body. So the rib actually articulates with two vertebral bodies forming a bridge. So it kind of locks everything in there. Then we have the tubercle of the rib articulating with the transverse process. So the ribs connect posteriorly 3 different points. Costotransverse and costovertebral joints are synovial diarthrotic joints, and they provide plane or gliding movement. So far, nothing different. It's the same as the other joints. Looking at our oblique lumbars. Looking for that Scotty dog sign, signifying that we've got a good oblique position of the lumbar spine. Make sure that you're able to identify the different areas here. The transverse process is, of course, is the nose. The pedicle, looking at the pedicle on end as we're visualizing it, makes up the eye. The superior articular surface making up the ear. The inferior articular surface making up the leg. Of course, both of those making up the zygapophyseal joint that we're visualizing here, separating the ear from the leg of the next or the previous joint. Then that area between the zygapophyseal joint and the pedicle is the neck, or the pars interarticularis. In order to demonstrate the intervertebral foramina of the C-spine, how much does the patient need to be oblique? 45 degrees. Now, what Z joints are going to be visualized? What are we looking at? Sorry, I went forward. I didn't want to. Upside or downside? Upside. Upside, yes. C-spine is the upper spine. We're going to look at the side up on our obliques, posterior obliques, side up. It's the opposite for anterior obliques, right? 45-degree angle for obliques. On the lumbar spine, we're going to be, it's the lower end, it's the down portion of the spine. So the Z joints that we're going to look at there are going to be the downside on posterior obliques. Again, 45 degrees. T-spine, it's an upper part, 70 degrees. When performing the C-spine oblique, patients in an LPO, what is the required CR angulation and direction? So 15 degrees, cephalad, and remember that if we're doing anterior obliques, that angle is going to be reversed, so it'll be caudal. Okay. Which position demonstrates the intervertebral foramina furthest from the IR? We're going to assume that this is talking about the cervical spine, right? LPO demonstrates the right, RPO demonstrates the left. So these are some more of those questions. Go through there, see if we need anything. That'll take us to our bony thorax. So we're at the end of our lecture for today. Does anybody have any questions? Any points that need to be cleared up? Anything else that needs to be explained? No? Okay. Well, thank y'all for being here. Continue to have a good Monday. If you haven't had a good Monday, go ahead and start having one now because we're done with lecture. Y'all have a great night too. I'll holler at you Friday and I'll see you next Monday, okay? Good deal. Y'all take care now. Checks out.
Recording stopped.